Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. My name is Mike Sullivan, and in this program we'll be discussing OB-related emergencies. Now, the National Registry has outlined 5 core objectives for this program. First off, we'll identify abnormal presentations during childbirth. We'll discuss management of a patient with an abnormal presentation during delivery. We'll recognize the need for neonatal resuscitation. We'll discuss the management principles of neonatal resuscitation, and we'll describe routine care of a newborn not requiring resuscitation, which fortunately for us is the vast majority of field deliveries that we will deal with. In addition to this, our team has identified a few enhanced objectives. We'll be reviewing the anatomy and physiology associated with OB emergencies and pregnancy, and we'll also review the stages of pregnancy and the maternal changes that go on associated with each one of the stages of pregnancy. This is largely due to the fact that although, yes, field deliveries do occur, the vast majority of OB emergencies that we respond to as EMS providers are not involving an actual delivery. Many of them are involving some other chief complaint somewhere along the 10-month journey from conception to motherhood, and therefore we need a little bit of background in those, as we'll be managing those patients more likely. Now, let's look at the female anatomy for a second. We start off with the ovaries. Now, the average female will have 2 ovaries, and these contain the eggs. One egg is released roughly every 28 to 30 days, and that egg will float down its fallopian tube toward the uterus. If that egg becomes fertilized by a sperm cell, then it will actually implant. Now, if it implants on the lining of the uterus, that's where we expect it to or would like it to implant. However, if it becomes implanted in the fallopian tube, this is known as an ectopic pregnancy, and we'll talk a little bit more about some of the issues presented with that when we get into the first month of pregnancies. Now, the uterus builds up a wall and allows the embryo to implant and therefore grow within the uterus, and eventually, 9 months later or 10 months later, we have a baby. Now, the stages of pregnancy for a human female divided into 3 trimesters. Overall, it's roughly 40 weeks from conception to delivery, and each one of the trimesters is about 13 weeks apiece. You can see here as the baby begins to develop month by month and starts out as just a small clump of cells and eventually the baby that will deliver. The first trimester is weeks 1 through 13, second trimester weeks 14 to 27, and the final trimester weeks 28 to 40. Now, during the first trimester, some of the things we'll begin to see. The mother may present with hypotension. This is due to the fact that as the baby begins to develop inside the womb, the mother has to supply blood not only to that, but also to the womb itself. Thus, even though she is not losing a significant amount of blood, her container size is getting much bigger. This leads to relative hypotension, the same amount of blood in a larger container. Thus, her blood pressure will tend to drop. Associated with this will be tachycardia. This is a compensatory mechanism to help the limited amount of blood provide nourishment and perfusion to all the newly expanded uterine area, and therefore the body is having to work a little bit harder. In addition, with that working harder comes hypoglycemia. The developing fetus is not only going to need nutrients, but all the expanded cells of the uterus will as well, thus burning more sugar, so even if the mother was on a consistent caloric intake with what she was pre-pregnancy, now there's much more demand placed on the body, so therefore she's eating for two, so to speak. Vomiting can also play a role, as the mother may experience morning sickness. Now, if the mother is vomiting on a regular basis, she may not only have trouble keeping food down, however, she may also be reluctant to eat as she gets frustrated, feeling that every time she tries to eat, it's going to come back up. These all come together to lead to the hypoglycemia. The mother will typically experience some light vaginal bleeding and maybe have some lower abdominal cramping as the uterus expands. So, what do we see as far as the fetus? Well, the implantation causes the spotting of vaginal bleeding we mentioned before. Blood and oxygen demand is going to begin to rapidly increase to supply the fetus and the extra uterine tissue. Syncope can be a common presentation for the mother until the blood volume increases. As we said, her container is on a continuous expansion, and therefore her blood volume is having to play catch-up. This is also the time when most spontaneous abortions or miscarriages will occur. Many of the time you'll see a high-risk pregnancy who's in her first trimester. She's got to be extremely careful, because this is when the baby hasn't really established itself that well in the uterus and therefore is likely to be lost, unfortunately. Now, our care for the mother during the first trimester is primarily supportive care. We may need to provide fluid resuscitation for vomiting, or may need to consider ECG monitoring during transport based on the nature of her presentation and chief complaint. However, if you have a first trimester mother who is having severe abdominal pain, or severe abdominal pain accompanied with major bleeding, we need to consider possible ectopic pregnancy. If she has not had an ultrasound done yet, and we don't know where the egg is actually implanted, and she's in the first month or 8 weeks of pregnancy, we may have to worry about where the egg is actually implanted. Is it in a fallopian tube? Now, the worst part about an ectopic pregnancy is, yes, there's a good chance she'll lose the pregnancy. However, this can cause significant internal injury to the mother, damage to the fallopian tube, and potential loss of the fallopian tube if it ruptures. So therefore, an ectopic pregnancy, again, severe pain, likely one-sided, major bleeding, with a female of childbearing age and any possibility she could be pregnant, ectopic pregnancy is the worst possible outcome, and therefore this needs to be high on our list of rule-outs. Ideally, an ectopic pregnancy or suspected ectopic needs to go somewhere they have emergent surgical capability. This is not to knock your local community hospitals. However, if it's 4 a.m. on a Saturday morning and you've got a woman who's got a significant possibility of an ectopic pregnancy, She needs to be somewhere that they've got a surgeon on the property readily available to address this, not only for her well-being, but also for her long-term well-being as far as the salvaging of her fallopian tube. This can cause significant internal bleeding, and again, given the fact that it's a non-compressible site, it's very complex to manage. Now, moving on to second trimester considerations. During the second trimester, as the baby continues to develop, the mother may develop gestational diabetes. They'll begin screening her for this and other issues regarding sugar tolerance. Later in the second trimester, the mother may experience some preterm labor. The mother may be discovered to have placenta previa, and we'll talk about that condition later. Little by little, the blood pressure and heart rate stabilize, as even though the mother is still growing, the body at this point is starting to catch up with it, and so therefore, hopefully, the body will be able to maintain homeostasis more easily. The mother may still experience some morning sickness, but that will typically subside later into the second trimester, and the mother may actually gain more and more energy. Our supportive care for the mother in this, again, is likely oxygen, fluids if needed for either vomiting or hypotension, ECG depending on her chief complaint. Now, if we're dealing with a mother with preterm labor. The second trimester, again, is weeks 14 to 27. A 14-week-old fetus is not typically viable. 27-week fetus is very viable, but may require specialized care. So depending how far along the mother is, we may need to go to a specialized destination, especially if she's having preterm labor or some other type of complication. We may need to go somewhere that they have a NICU. This is largely dependent on your community and your resources. If you have a local hospital that doesn't have a NICU that's 10 minutes away, and the closest place with a NICU is 2 hours away, we may need to go to the local hospital where they can try to stabilize and possibly ship the mother either by ground or by air. On the other side of the coin, if your NICU is 30 minutes away and the community hospital is 20, that would probably be an indication that we should go somewhere where there is a NICU just in case that is needed, because again, a 27-week fetus is definitely going to need specialized care, and the NICU is going to be better staffed and equipped to provide that for them. Okay, now as we move into the third trimester, weeks 28 through 40. Again, gestational diabetes is still possible and the screenings will continue. The mother may have blood pressure and edema monitoring for the potential of developing preeclampsia or eclampsia. Respiratory distress may be common with tachycardia, especially as the height of the fundus rises and may compress the diaphragm. As the fetus gets larger and larger, we have more possible concern with it keeping the diaphragm from moving down. This can be especially pronounced in ladies who are smaller of stature, or shall we say, shorter. This is because there's not that much room between the upper end of the fundus, as you can see in the picture, and the inferior aspect of the diaphragm. If the diaphragm can't move down because there's a baby in the way, mom can be short of breath, and again, respiratory limits, tachycardia will all come into play. Now, there are several common complications we see. One of these would be gestational diabetes. Again, it may be diagnosed in the second or third trimester. Preeclampsia or eclampsia. Now, typically, again, that comes in around week 20 or later than that. Placenta previa. This is something that will typically be found on the ultrasound. Abruptio placenta, which can happen later on in the third trimester, and again, it can cause significant problems, so we'll talk about some of those. Now, when we look at gestational diabetes initially, mother will be screened for this multiple times during the second and third trimester. If she develops gestational diabetes, she may be put on insulin or oral medications for it, and the fact that mom does have gestational diabetes leads us to potentially having a larger baby and therefore a higher incidence of cephalopelvic disproportion, which is where the baby's head is too large to pass through the mother's pelvis. So to have in the back of our minds, again, it doesn't automatically correlate over, but there is a higher risk of it with gestational diabetes. Now, when we get into preeclampsia or eclampsia, again, this can manifest about the 20th week of pregnancy, and it may actually manifest after the delivery, sometimes up to 10 days or more. The risk factors for eclampsia or preeclampsia are first pregnancy, a maternal age younger than 18 or over 35, chronic hypertension, renal dysfunction, maternal diabetes. Race is an interesting pickup because African Americans are more at risk for this, and a prior history of preeclampsia with a previous pregnancy. Again, it doesn't always correlate across, but the more of these she has, the more possibility we could be dealing with preeclampsia. Now, preeclampsia in and of itself presents with a triad of symptoms. First one being swelling or edema of the face, the ankles, or the hands, hypertension, and lastly, protein in the urine. Now, while we cannot screen for protein in the urine in the field in most cases, if mother is excessively hypertensive and we're beginning to see swelling in the feet, swelling in the ankles, swelling in the face, this would let us know that mother is at least at that stage preeclamptic. Now, preeclamptic can become severe preeclampsia when you see hypertension with a systolic over 160 or a diastolic over 110. In some cases, we may actually begin medicating at this point in an attempt to prevent it from developing to full eclampsia. Other symptoms associated with severe preeclampsia: headache, dizziness, nausea, vomiting, agitation, major weight gain, and visual disturbances. Now, the difference between severe preeclampsia and eclampsia itself: in eclampsia, the mother is actively seizing. This must be treated immediately. So again, some services will treat it at severe preeclampsia in a prophylactic measure, while some will not and will try to avoid it and wait till we get all the way to eclampsia. Now, we know preeclampsia left untreated or unmanaged has a high likelihood of progressing to eclampsia. When you're dealing with severe preeclampsia or eclampsia, high flow oxygen, definitely. In some cases, they'll use magnesium sulfate, especially for active seizures. If you're dealing with a patient with active seizures, we'll have a loading dose of up to 4 grams IV push over 3 to 5 minutes. Hopefully, this will stop the seizures. If it does, we'll follow up with an infusion or a drip of 2 grams per hour for up to the first 24 hours. In addition to this, you may consider many antihypertensives. In light of the fact that there are so many options out there these days, check with your med control doc based on what you've got on your truck and what you have in your formulary as to which one he would recommend you use, or if he or she would recommend you not treat this or not use an antihypertensive. Again, this is very agency specific typically. Overall, there's various schools of thought you will see as far as how early we should treat preeclampsia and also whether we should treat the hypertension in the field or not. So that would be, again, an agency by agency med control decision. Now, let's move on to placenta previa. This is a condition where the placenta develops partially or completely covering the opening of the cervix. This should be determined as part of prenatal care based on the ultrasound, and the mother may be very well aware of it, and it may preclude actually being able to vaginally deliver the baby, depending on how badly the occlusion is, or how badly occluded the cervix is. So now at this point, if the mother tells you in the assessment that, well, she's got placenta previa and they were going to have to do a C-section, that would always be an automatic rule out for a field delivery. On the other side of the coin, if the mother's had absolutely no prenatal care, she may not know. Now, placenta previa may develop with some vaginal bleeding as the cervix starts to expand during dilation, during the phases of labor, and so we need to be aware of that. Another issue we can see in the delivery is abruptio placenta. Now, this is a condition where the placenta begins to tear away from the uterine wall prematurely. This will typically present with severe sudden onset pain, and it may or may not present with severe bleeding. In the picture you see here, the inferior aspect of the placenta is no longer attached, and so therefore the bleeding is coming out the cervix. However, had that inferior aspect still been attached, there can be a significant pocket of blood develop between the uterine wall and the cervix, but the bleeding may all be contained. Typically, this is going to be much more painful than placenta previa, and that's one good distinguishing rule out between the two of them. Now, as we look at deliveries, in the big picture, there's over 3.7 million babies born in the U.S. each year. The majority of them are delivered in the hospital and are delivered without incident. Some individuals choose to deliver outside the hospital. This is their plan. In 2006, almost 1% of the deliveries in the country were non-hospital deliveries. This was up 5% from the prior year, and this is a trend we're seeing more and more. Now, of these pre-hospital deliveries or extra-hospital deliveries, 70% of them occur at home, and 28% occur at some type of non-hospital specialty birthing center. Now, if a home birth is planned, it's likely to be low risk. These are typically coordinated with either a midwife or some other specialist or some other type of birthing coach, and most of the midwives that I've dealt with do an excellent job screening their patients. They have already talked to the patient, and the patient has been receiving regular prenatal care, and they've developed the fact that they foresee this to be a very low-risk birth, and so therefore it's appropriate to do at home. So when you get to a planned home birth, you realize that much of the concerns that we would have don't really apply because it's likely to be a very low-risk situation. The mother hasn't had major complications in the past. We're not dealing with an undiagnosed placenta previa. The mother does not have a lot of risk factors related to the birth, and therefore, for the most part, we won't even end up getting called to those. However, if it's an unplanned or emergent home delivery, or some strange problem does occur with a planned home delivery, that's where EMS is likely to become involved in it. So again, the vast minority of all the deliveries that go on in the world are the ones that we'll actually be involved with. Now, when we get involved, there's a few choices that we need to make based on our triage. One of the first things we need to try to figure out is where we're going to do this. Ideally, the perfect choice for a location would be the hospital. Ideally, they've got the most resources, more than we have in the field. And if we can get there in time, that's wonderful. But this is largely based on our distance between the scene and the hospital, the travel or road conditions, the weather conditions, what potential complications are going on. Again, if we know the mother is not going to be able to deliver vaginally and is going to have a C-section, this would definitely be a choice. How about the gestational timeline? How far along is mom? Can we go to the local community hospital, or do we need to go to a NICU facility up the road? Like I said earlier, depending on your geography and where you are, what your local facility capabilities are, what your community hospital, where mom wants to go, how far it is to the NICU, these are all things that weigh into not only where we're going, but which hospital it will be. Now, our second choice, if it doesn't seem like we'll be able to get to the hospital for whatever reason, let's say the mom is already crowning, or we're too far from the hospital, or for some reason you're dealing with significant weather issues. Let's say it's snow and ice on the roads, and you know it's going to be at least an hour or more travel to the hospital because everyone's having to do 20 miles an hour slip and slide. Home is your second choice. Typically, as long as you're going to have minimal potential complications and mother doesn't know of any reason why she can't have a normal vaginal delivery, we can deal with it at home. This is actually going to be a better choice than trying to do it in the unit. Delivery in the back of the unit is a very difficult choice. We have, number one, significant limits on our space and access. We have limited personnel that can fit in the back of the truck. We may have issues as far as where we're at, the parking or the scene. If we're trying to get mom to the hospital and we end up having to basically change our plan and deliver in the field, we have to come up with a safe place to park the ambulance where we're not going to be obstructing traffic or get hit by traffic while we're dealing with the delivery. So again, if we think we can make it to the hospital, great plan. If we don't think we can make it to the hospital, mom's already crowning, get your equipment, we'll set up at home. Ideally, I've always tried to avoid a delivery in the unit just because of the fact that we're going to be very limited on what we have space-wise and personnel and resources. So when we make our assessment, how do we choose? Well, we'll start with assessing mom with our customary primary survey like we always do, ABCs. We'll assess her baseline vital signs and get a sample history. Pay particular attention to any medication she's had in the last 12 to 24 hours. Those will be on board with the baby. Does mom have a history of gestational diabetes? When we look at the physical exam, has mom's water broken? Is the baby already crowning? These will all weigh into our decision. We'll continue with our focused assessment based on mom's pregnancy and her delivery plan. When we look at gravida, that's the number of times she's been pregnant. We look at para, that's the number of live deliveries she's had. Ideally, mother's gravida should be one less than her para. If mom is gravida 4, para 1, we now know that mother has had 2 previous problems, and that's going to potentially indicate complications on this delivery. Look at her due date. Is she term? Typically greater than 37 and under 42 weeks. That's normal term. So ideally, these patients will be able to deliver a normal weight neonate as opposed to something significantly underweight or significantly overweight. What was her prenatal care? What was her delivery plan? Has she had an ultrasound? Does she know what her plan was? Did the doctor say that she'd likely have to have a C-section? Do we know if the baby has turned? Or do we not know anything and mother can't remember or has not seen her doctor in 3 months? Those would all, again, be concerns we'd have. Look at her contractions, not only how long they are, but the timing in between them. Contractions coming closer and closer together tend to tell us that delivery is much more imminent. The number of babies due in multiple gestations can present a series of challenges, and we'll talk about some of those later. Expected complications. What issues does mom have that may make this more complicated than just the average delivery? Like I said, any one of these all phase into how we're going to deal with this. Now, if we're going to deliver at home, let's look at the stages of labor. Typically, stage 1 may take as little as 8 or up to 12 hours. It starts with the passage of the cervical mucus plug, and then the dilation and effacement of the cervix. Contractions during this phase are typically about every 5 to 15 minutes, so if they're 5 to 15 minutes apart, we know that we're pretty much in stage 1. Now, once the cervix is fully dilated out to 10 centimeters, we begin stage 2. Stage 2 ends after the fetus itself is delivered. During this phase of labor, you're looking at contractions 2 to 3 minutes apart. So again, just quickly timing contractions can let us know how far down the delivery road we are and how imminent the delivery may be. When we look at stage 3, the delivery of the placenta, this can take, they say, 10 up to 60 minutes. However, for the most part, it occurs with minimal issue. Now, once we make the decision that we're going to have to deliver on scene, we need to prepare for this imminent delivery. This can be due to the fact that the baby's crowning, or the timing of contractions, the distance from the hospital, a variety of factors. Ideally, if we have additional clean towels there, we can try to put them in the dryer to warm them up somewhat. We'll need those later. We need to make sure that we get O2 and IV in place for mom. Consider getting at least a second line as an INT if possible. Do you have a spare O2 cylinder in case we're on scene for an extended period of time? Do you have a regulator for it in case you need to use blow-by for the neonate while keeping O2 on mom? We'll get our equipment, of course, our OB kit in, and we can start working to set that up. Also, we probably want to bring our PPE kits in, at least one for whoever's going to receive and possibly one as a backup. If you have the ability to put tarp or plastic sheeting on the bed, mom will definitely appreciate it when she comes home, as I'm sure she doesn't want to come home to this mess. We want to get a neonatal BVM, O2 tubing available. Again, we want to have as much of our equipment readily available and set up wherever we are in the house as our field delivery unit. This is the point where we also want to start thinking about additional personnel. Even additional basic level personnel or additional ALS truck if you can, because that way we have more people. We know at this point we have one patient, we may well have two or three very soon. Now, we'll begin positioning the patient on her bed, and we want to tilt her slightly to avoid compressing the inferior vena cava. If time permits, again, drape or tarp the bed. Some patients will want to use an alternate pushing position, such as a sitting up semi-Fowler's position. Some may want to use a kneeling or standing position, in which case they actually are using gravity to assist with the delivery and the pushing. They may want to use a lateral position. Try to keep mom as comfortable as she can. We'll drape the patient with sterile drapes and have another provider assigned to monitor not only the mother's vital signs, but to coach and provide supportive care for her throughout this event. We'll don any additional PPE, and this is where we'll pop open our PPE kits and get ready, again, for whoever's catching and a backup if possible. Now, assuming everything goes right and the baby presents head first, this is what we would call a cephalic presentation. And in this, we'll basically be doing nothing more than just assisting the delivery, letting the mother do most of the work, and we'll be assisting as she does it. One of the first keys is we need to make sure we control the delivery speed, providing gentle pressure or resistance as the baby's head comes out. As the newborn's head begins to emerge, we want to support the head as it turns. We want to resist the urge to pull on the head or twist it in any way, again providing primarily support or resistance to mother's pushing to prevent a precipitous delivery. Now, if the membranes do cover the head or the face after it emerges, we may need to gently tear the sac away from the baby's nose and mouth to allow the baby to begin breathing. If the airway appears to be obstructed, cradle and support the newborn's head and clear the airway by suctioning with a bulb syringe. Gently guide the head downward to allow the upper shoulder to deliver, allowing it to pass underneath the pelvic bone. Gently guide the head upward once the upper shoulder has delivered, and that will allow the lower shoulder to deliver. Now, once the shoulders are delivered, the trunk and legs will typically follow rather rapidly, and we'll support the newborn as it emerges. Once the newborn is delivered, we want to maintain its body at the same level as the vagina to prevent blood from either draining back or overloading the baby. Wipe away any blood or mucus from the newborn's nose and mouth with a sterile gauze 4x4. And if you do have any noted airway obstruction, you should have your bulb syringe ready to suction the mouth and then the nose. Always remember we want to suction the mouth first. Record the time of delivery, and then you can begin drying, stimulating the newborn with sterile towels. Make sure to keep the newborn warm and conserve body heat. Remember, the baby has been living in 98.6 degrees for the last 10 months. All of a sudden, the baby is now at room temperature and cold and potentially wet, so we want to make sure we're keeping the baby warm enough. As you begin to assess the neonate, the first questions you should ask yourself: is this a full-term gestation? Does the baby have good muscle tone? Is the baby breathing or crying adequately? If the answer to these three questions is yes, they'll need primarily just supportive care, and the infant should be able to stay with the mother while this care continues. If the answer to any of these is no, we need to begin our resuscitation procedures. Now, when you look at resuscitation, again, we'll begin suctioning, warming, drying, and stimulating the neonate. We may use, again, warm, dry towels, may begin gently rubbing the back of the child in a circular manner, and most neonates won't require any support beyond this level. At about the 30-second mark, we should assess the baby's heart rate. A heart rate less than 60 would indicate we need to get aggressive care, potentially beginning CPR and bag valve ventilation. A heart rate between 60 and 100, we'll look at mild care. We'll stimulate the baby, possibly blow by oxygen, again encouraging the baby to breathe on its own with minimal intervention. If the heart rate's already over 100, again we're in a primary supportive care mode. We can consider initiating our APGAR scoring and work from there. Now, when it comes to managing the umbilical cord, handle the cord with care to avoid damaging it or ripping it. Once it has stopped pulsating, we want to wait, and then we'll tie or clamp it. Now, for the book answer, we should be cutting the clamping the first clamp at least 4 to 5 inches from the neonate and then 2 inches beyond that. I will say, having gone to a couple of neonatal classes, the vast majority of physicians have said they won't ever complain about us leaving too much cord on the baby. They'll always complain if we don't leave enough. So remember, leave them at least 4 to 5 inches from the baby and then 2 inches beyond that. Once the cord is clamped securely, go ahead and cut between the clamps. Monitor the cord end for bleeding. If bleeding does initiate from the cord, add another clamp proximal to the first, which would be between the baby and the existing clamp. Okay, so now that we've cut the cord, it should be about time to reassess after 1 minute. So we're at the 1 minute and 30 mark now, and again, based on the neonate's heart rate, we'll initiate care. Heart rates under 60 continue to require aggressive care, and at this point we may want to look for intubation possibilities or look for causes such as low blood sugar, or could the mother have been on some medication that we may need to use Narcan on the neonate. If we're dealing with a heart rate of 60 to 100, we may need to stimulate ventilations with a bag valve mask. And again, if the heart rate remains above 100, maintain body temperature, and it's primarily supportive care. We'll do this for 1 minute, and we'll go through our next reassessment at the 2 minutes and 30-second mark. At this point, if the heart rate remains under 60, we'll consider establishing an IV or IO. We may have administered a medication at this point to try to correct a treatable cause, such as low blood sugar. If the heart rate is between 60 and 100, at this point we may need to consider intubation. And again, if the heart rate stays over 100, maintain core body temperature. Ideally, by this point, we may have mom cradling the baby and primarily supportive care on our part. At the 3 minute and 30-second mark, another minute later. At this point, we may look at establishing an IV or IO to administer epinephrine. If the heart rate is between 60 and 100, we may consider initiating chest compressions. And of course, over 100, we're in the green and we're carrying on with supportive care. Now, when we get into administering meds for neonates, let's look at epinephrine for a minute as far as neonatal pharmacology. Most neonatal care rarely gets to this point. It rarely involves medications. Most of our patients respond far before we get to this level of care. Typically, a little BVM ventilations, a little blow-by oxygen, maybe some stimulation, some warming, drying. However, if we do get to this, we need to make sure our dosing regimens are correct. In some cases, medications may even need to be diluted for use in neonates. Now, when you're dealing with a neonate who has refractory bradycardia, which means that it's still under 60 regardless of our efforts by this point, we'll use epinephrine that's a concentration of 0.1 milligram per ml, or 1 to 10,000, our cardiac arrest epi. The dose, when you're administering it via IV or intraosseous line, is 0.02 milligrams per kilogram, repeating it every 3 to 5 minutes as long as the bradycardia exists. However, if we don't have our IV or IO established yet, we may administer the first dose via the ET tube. This would be 0.1 milligram per kilogram. That's our option if we don't already have an IV or IO available. However, understand that ET absorption is not going to be as reliable as IV or IO absorption. Typically, these will be the only meds we'll use in neonatal resuscitation unless we've had to give, say, Narcan or something for a blood sugar level. Now, when we get into APGAR scoring was actually developed in 1952 by Dr. Virginia Apgar. She was an anesthesiologist and also an OB specialist. It to this day remains one of the best ways to assess the condition and perfusion of a neonate. The APGAR score is made up of 5 factors. Each one is graded on a 0 to 2 scale to arrive at a score of 0 to 10. This should be obtained at minimum at minute 1 and 5 after delivery. Some agencies and providers continue to use it every 5 minutes thereafter until arrival at the hospital. I strongly recommend this, as again, it's a lot easier way to evaluate a child and their progress while you're transporting, as you won't be able to customarily get normal vital signs to monitor. Now, the APGAR score again is made up of appearance, pulse, grimace, activity, and respiration are the 5 factors. As you can see on this chart, each one gets a 0, 1, or 2 score based on the neonate's presentation and appearance. Between 7 and 10 is considered fairly normal. 4 to 6 is moderately depressed and will likely be in your yellow category of resuscitation. 0 to 3, of course, would need immediate resuscitation and would likely correspond fairly well to the red category we were going down. Now, let's talk about the placenta. As we said, the third phase of labor is typically within 5 to 30 minutes, maybe up as long as 60 minutes of the newborn's arrival. Mother may state it feels like her labor is starting again. She may feel a couple of contractions or may feel some discomfort. However, we don't necessarily need to delay transport of the mother or the neonate for the placenta to deliver. This is perfectly normal and should happen on its own. Ideally, we need to collect and bag the placenta for transport with the mother to the hospital, as they can inspect it to make sure the entire placenta has come out and none is remaining inside the mother, which could cause a residual infection. Now, some families may want to keep the placenta. There are some families who want to plant it in the yard with a tree. They feel that this is a sign of good luck, and there are actually some cultures where they actually cook and eat parts of the placenta. Again, we understand that, and we try to be as culturally sensitive as we can to their needs. However, strongly encourage them to at least let the ER doc look at it first and evaluate it, and that way we can determine to make sure that the mother's well-being comes first, and we work from there. Now, as I mentioned earlier, throughout the labor process, one crew member should be assigned to support and monitor the mother. This may be the same crew member throughout, or it could be rotating crew members. However, at all times, we should ideally have one crew member assigned to her care. Once the placenta has been delivered, we can go ahead and have that crew member massage the upper side of the fundus to assist in controlling hemorrhage. Ideally, there should be minimum postpartum bleeding, less than 500 mLs. The more we can do at this point to assist the mother in controlling bleeding, the better off she'll be, so therefore we want to make sure that we're not forgetting the mother in the process of resuscitating the neonate or dealing with the neonate. Now, another term we hear about much in OB emergencies is meconium. Now, there's no way to know if meconium will be present until the amniotic sac actually breaks. This is something we unfortunately can't really plan for. Meconium is the baby's actual first bowel movement. It may be greenish or black in color and may be thick and have tar-like consistency. Meconium staining is typically an indicator of some sort of fetal distress. The presence of meconium may also complicate patient management. So when you see meconium, we know, okay, number one, the baby was in distress, and number two, the management may be more complicated. Now, if you have a baby with meconium present, if the neonate is vigorous, with good respiratory effort and good muscle tone, will likely not benefit at all from suctioning. Should stay with the mother and again receive the initial steps of newborn care. We may need to use gentle clearing of meconium from the mouth and nose with a bulb syringe or a sterile gauze pad. Now, if meconium is present and there's a fetal distress, poor muscle tone, and or respiratory distress, immediately initiate resuscitative measures. We may need to initiate positive pressure ventilation if the heart rate is less than 100. We may need to consider intubation for respiratory distress. We will not intubate solely for the reason of suctioning. However, if we do need to intubate, we may have to suction as well. This pretty much winds down the, okay, mom had a normal cephalic head first delivery. But there's a lot of other presentations we may have to deal with out there. So, as we look at abnormal presentations, the first one we'll discuss is breech presentation. This can be either buttocks or possibly feet first. As you can see, when the baby's in good position, the head is down, preparing to come out, and that would be our normal cephalic presentation. However, if we have the baby either buttocks first or breech first, where they come out feet first, that will definitely complicate our management and complicate delivery. If you're faced with a breech presentation, first off, prompt transport. We want to avoid a field delivery if possible. However, if based on where we're located and the road conditions, field delivery is unavoidable, we'll do our best to support the buttocks and the legs. We don't want to pull anything. And if the head does not deliver within 3 minutes, again, begin immediate transport. We may need to actually insert a gloved hand into the mother's vagina and use our fingers to create a V over the infant's nose and mouth to push the vaginal wall away from the nose and mouth and facilitate breathing. This is especially true if it also includes the cord. Thus, we need to make sure the baby is able to get oxygen. If we're faced with a limb presentation, i.e. one arm or one leg, avoid touching the limb at all and do not attempt delivery. Provide supportive care for the mother, definitely high flow O2, and transport the mother in the knee-chest position at that point. Now, when faced with multiple gestations, they can cause a variety of complications for us, largely dependent on if the babies are in the same sac or if they're in separate sacs, are they on the same placenta or different placentas. That can depend on how we manage it. Most of the time we'll deliver normally, but recognize that we're going to need a lot more equipment and a lot more personnel. Remember, these situations can change quickly. Trying to deal with one baby and the mother can be difficult enough for a crew. If you're dealing with 2 babies or more, you can potentially have 3 critical patients on your hands. Also, when dealing with multiples, we know that they're typically born prematurely and may have respiratory compromise. In addition, they may also have a low birth weight due to the prematurity. So this can all complicate our management. So definitely, if you're in a field situation and you realize you're dealing with multiple gestations, get help on the way to you, as you will need more resources. A prolapsed cord. Now this can be very disconcerting when we see the cord coming out first, not only because we know the cord should not be there, but also because the baby may actually occlude the cord partially, depriving itself of oxygen. When dealing with a prolapsed cord, immediately transport in Trendelenburg or knee-chest position, and we may need to again insert 2 fingers into the vaginal canal to remove the pressure from the cord and keep it from being occluded. We also need to keep any exposed cord moist with sterile dressings. You should never attempt to pull the cord or attempt to reinsert it in the mother's vagina. Now, shoulder dystocia. This is a less common event. However, when the shoulder impacts the pelvic outlet, especially on the upper shoulder up against the pubic symphysis, it may lead to brachial injury, clavicle damage, or fetal hypoxia. This may be indicated by the head presenting and then drawing back up in the vagina. What's happening here? The baby can't pass under the pubic bone, and so therefore they're lodged against it. In this case, we need to do what's known as the McRoberts maneuver, whereby the mother will put her buttocks off the end of the bed with her thighs flexed upward, and we will apply a firm, steady pressure above the pubic symphysis to assist the baby in going underneath the pelvic bone. If this fails to deliver, again, immediate transport of the mother, trying to do this while en route. Here's an example, a good picture of what we're actually doing. As you can see here, the neonate's upper shoulder is stuck up against the mother's pubic symphysis, so therefore we need to try to guide the neonate downward to assist the rest of the baby in delivering. Now, another potential complication we can deal with is a nuchal cord. That's a term for when the umbilical cord becomes wrapped or tangled around the baby's neck. Now, this condition is more common, can occur in up to 30% or more of all births, and represents a very common problem occurring in the field. We can use 1 or 2 fingers to attempt to lift the cord over the baby's head or out from around the baby's neck. And if we're unable to do this, we need to carefully clamp and then cut the cord. This again is fairly simple to deal with and usually will not preclude delivery. However, we'll just add a couple of extra steps as we go about completing our delivery. Shows here not only do we have the cord wrapped around the baby's neck, but as you can also see, the baby is at this point presenting feet first. I'm hoping that the munchkin turns around prior to the actual delivery. Otherwise, they're going to have a breech with a nuchal cord. That would be much more complicated. In closing, although OB calls represent a small portion of our responses, they do present specific challenges for providers. Always remember in dealing with emergent deliveries that you're treating at least 2 patients and maybe more. We need to make sure that in all the chaos and all the work we're doing to deal with the neonate or neonates, that we don't forget we're dealing with mom as well. We need to make sure we're providing her the proper quality of care and make sure that we've got someone assigned to monitor her. Lastly, although childbirth is perfectly natural and women have been doing it for years, we need to be prepared to support mom in case any of these variety of complications occurs. Ideally, there won't be any complications and the delivery will go off without a hitch, and you may even get a stork pin from your agency for it. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.